thank all of you for giving me the opportunity to talk here today. From the presentations in the last 2 days of the incredible genius at the technical end, all the way up to the sublime Jay Saunders and Molly Coy, sort of looking at where this is all going. So what I'd like to do today is kind of tie some linkages between the detailed engineering opportunities and some of the sublime opportunities that we have in front of us today. The second thing I wanted to do is comment on an earlier comment about Kaiser Permanente doing shadow pricing. So in the commercial world, shadow pricing generally means that you just stay right at the price point of the market, and the distributable profit is the gap between your costs and that revenue. In the case of Kaiser Permanente, the health plan is a not-for-profit institution. So as in Peter Drucker's parlance, excess revenue or profit is actually reinvestment opportunity. And so what we do with any excess revenue in any particular year is cycle that into our investments in technology, new models of care, and improving outcomes. So I would quibble a little bit with applying the traditional term of shadow pricing with how we operate, because we see all of those monies as being a reinvestment opportunity in our members. So what I'm going to try and do today again is cover a pretty fast pace. I'm going to violate 2 cardinal rules about presentations. First is no more than 1 slide a minute, so I have 40 and 30 minutes. And the second is not to put too much on any individual slide, and I'm going to try and just pull out the salient features. So fasten your seatbelts. Okay, so this is a Rorschach of the talk I'm going to give, and I'm just going to come back to that after giving you 5 seconds to look at the Rorschach. A couple of quick of my favorite quotes. So Alex Haddad is recognized in Wikipedia as the human internet. He's a friend of mine. He's absolutely amazing. He was asked by the World Health Organization to give a definition of health in 2011, and this is his definition. Health is the capacity of an individual and community to adapt and self-manage in the face of social, physical, and emotional challenges. This is all about resilience. William Gibson, the sci-fi writer, famously said, "The future has already arrived, it's just not evenly distributed yet." So there's virtually nothing we're going to talk about that isn't already here, but is very unevenly distributed. Einstein said a solution should be as simple as possible, but no simpler. H.L. Mencken said, "For every large complex problem, there's at least one simple solution," and it's almost always wrong. And then John Ioannidis, Stanford prof, who spent his career studying the half-life of facts in medicine, and he's shown that over 41% of published medical truth has subsequently been disproven. So as we go into this exponential era of big data and so forth, we're going to find that the half-life of ground truth is going to get shorter and shorter as we discover more and more. So quick survey, this is the audience participation card. Show of hands, how many have exercised at least once in the past week? Okay, 5 times in the last week. Okay, those of you that still have your hands up 5 times in the last week, how many of you have your genome sequenced? About 6. Okay, 5 years from now, over half this audience, at least 10 years, everybody. There's a gene for Alzheimer's, and if you're heterozygous for that gene, you have twice the risk of developing Alzheimer's disease. It's all probabilistic. But those of you that have your hands up, if you have that apolipoprotein E allele, and you exercise 5 times a week, guess what? Your risk of Alzheimer's goes right back to baseline. So it illustrates the nature-nurture aspects of health in a really critical way. How many of you have ever worn a Fitbit? How many of you have one today that you can hold up? 3. Okay. Thank you. I'm going to make a point about that. How many of you had your flu vaccine this year? Okay. Really simple, easy way to save yourself a week of misery. How many of you have emailed your physician? Maybe 20%. How many have more than 2 mobile apps on your phone? More than 6? More than 24? More than 120? Okay, we got 6 hands up. Does anybody recognize, we've got a lot of engineers here, what mathematical series is that? Somebody said it? It's factorial. Okay, 1 times 2 times 3 times 4 times 5. I'm going to come back to that, not in this talk, but in the panel this afternoon. It's very, very critical in the age of exponentiality. How many use Pandora? Okay, those of you who don't talk to someone you know who does, amazing. How many have heard of Patients Like Me? Oh, cool, okay. What percent of time do patients spend outside of the hospital and clinic? No, what percent of their lives are outside of the hospital and clinic? 99%. I did the math, it's 99.995% of our lives are spent outside of hospitals and clinics. That's where we make our healthcare decisions. That's why mobile and pervasive sensing is important. Who knows what disorders of lifestyle, how the disorders of lifestyle are currently threatening our national security? There's two fundamental ways. Any guesses? The first is that our cost structure for healthcare is 19% of every product we export. The rest of the world is about 9%. So we have a 10% handicap for everything we export. Second reason is that our military, and if we don't have a strong economy, we can't have a strong defense. Second is our military cannot recruit enough military recruits at the age of 18 who are not already so obese that they're disqualified for military service. Real threat to national security. How many have seen Weight of the Nation, the HBO series? If you haven't, I highly recommend it. You can do it anytime online for free. It's the first time HBO has put a series for free on the web. Produced by Institute of Medicine, NIH, and speaks to these disorders of lifestyle. Okay, this is a slide that I use just to pay homage to one of our physician founders, Sidney Garfield. He published this in 1970. This is his vision of integrated system support of integrated care delivery, published, as I said, 42 years ago. And we just completed his vision about 4 years ago with 100% automation of all our clinics and hospitals. This is a slide I used for the business case as to why we needed to spend and did spend billions of dollars implementing our health record. And it's all about the compression of transformational time. So my vision for what we would do at a health record is not make it easy to access information, but we would accelerate the learning cycle of making a discovery, modeling what would happen if we changed our decision support, looking for the end result of that in terms of health outcomes, and then constantly ratcheting up that transformational and learning cycle time. So we've already experienced that. We've gone from years and decades to discovery and deployment to literally minutes and hours between when we discover something and when we change a decision support rule and have every 115,000 physicians using that new information. So current status, we have 165,000 users. We did over 3 million hours of training. 60% of our eligible, 60 to 70% of our eligible patients use our personal health record online, on average, 19 times a year. There's over 25,000 emails sent between patients and physicians every day. We have a full hot failover between our data centers. In just a few years in our largest region, Southern California, we've saved over 12,000 lives documented as a result of these systems. And we have a steady stream of mobile apps with an exponential pipeline through our internal innovation grant process. So big data is not a new thing at Kaiser Permanente. We have 9 million members, 160,000 employees, 64 million square feet of facilities, over 40 billion revenues. We currently house 3 times the clinical data compared to everything in the entire Library of Congress, and we're doubling our data every 20 months. So we've been struggling with big data for quite a while. This is a great slide about what happens in Internet Minute. I'm only going to point out one thing at the bottom right. It says in 2015 it will take 5 years of watching videos to see what is passed across the web in 1 second, not a minute, but in a second. So we're all being flooded, physicians, consumers, everybody. We're all being flooded with information. How are we going to deal with that? So Geo Wiederhold, those of you from Stanford know Geo. He's an amazing guy. He's written many textbooks on databases. So he published a poem about a decade ago, refers to himself as the ancient hacker. It says, data everywhere and not a thought to think. Data everywhere and nothing helps you think. Data everywhere and how the mind does shrink. So this is from before the term big data was even coined. So what we really need to do is look at how we make sense of all the data. And there's a whole lot, so we have a model for that with evidence-based medicine, and we've done a lot of work around interoperability, semantic interoperability, open modular platforms. And now in mobile, I strongly encourage you to take a look at Open M Health. Ida Sim was on the stage here in the panel yesterday, one of the 2 co-founders of Open M Health, looking at interoperability for sense-making in the mobile space. So Roy Amara was a futurist, and he made this incredible observation about 20 years ago that futurists tend to overestimate the effect of a new technology in the short term and underestimate the effect in the long run. And so the implications for healthcare are that this emerging ecosystem of mobile, social, gaming, behavioral economics and health avatars will disrupt healthcare more than any other disruption in the evolution of the human species. And I don't feel hyperbolic when I say that. People say, oh, I wish I were alive, during the Renaissance era, or maybe 100 years from now. I would not want to spend this life anywhere but where we are right now, because what's happening now is on a scale never before realized in terms of changing and fundamentally disrupting how healthcare is delivered, and it may be another millennium before it happens again. So we're at an incredible time. So I'm going to show a series of cartoons on human evolution to illustrate a couple of points. How is the technology facing the future of our species? So this shows going from the erect to the hunched over PC scenario. Not a good one. This is the McDonald's scenario. The guy right before the pig is holding his bag of McDonald's Big Mac and his soda with high fructose corn syrup, which is still subsidized by the federal government maximally. This is showing that we evolved out of the sea, and in return we're dumping all of our trash into our ultimate mother. This shows skinny guy, fat TV, and then fat guy. And here's a picture. I think that's Justin Bieber. I can't tell for sure. But the caption says, "Go back, it's a trap." Okay, so these are all kind of ominous scenarios. At the end of the talk, I'm going to come back to where I think we're going with human evolution, all this. So how many people are familiar with the Gartner hype cycle? Okay, Gartner maps out new technologies over time. It actually mirrors the Mars law, expecting too much too soon with a hype, and then you crash, and then over time it just keeps recovering. So I took an old one because they don't like us using their new ones because that's their business. And I overlaid all these big capital goals. So the electronic health records way out there on the timeline. Past the hype cycle, it's real. Genomics is just coming out of the dip that we, lo and behold, discovered that identical twins don't have identical lives. What do you know? What a disappointment. Genomics is not deterministic. Except we knew that before we spent $2 billion on the Human Genome Project. And then the thing I've highlighted in bold red is pervasive sensing. And so we're still way on the uptick of the hype cycle of pervasive sensing, what it means, what it does, and I want to try and bring that home in terms of some of the real implications for us. So healthcare economics can be characterized as two runaway trains headed for a head-on collision. The first is on the provider side, we have a primary care crisis. Nobody's going into primary care anymore. Primary care is the most stressful, the lowest paid, and it's clearly a function of our incentive system. We pay more for doing stuff, so everybody wants to do procedures. Healthcare is behaving rationally. It's the incentives that are totally irrational. On the consumer side, we have diseases of lifestyle. So not only is our epidemics of obesity and diabetes causing all the ills associated with that, but the big killers, cancer, heart disease, strokes, and dementia, are all proven to be very much increased with obesity and diabetes. Exercise and sleep have significantly declined. Boomers are doubling the proportion of the elderly. So how will these trains collide, and what are we going to do about it with mobile and pervasive sensing? So I'm going to talk a little bit about exponentiality and the implications for healthcare and life sciences. Data types growing faster than Moore's law, just about everything. Location, geomobile, music and audio, time series, pervasive monitoring, genomics, social, exhaust. And it's across all three archetypes of data: text, images, and time series. So everything is growing exponentially. And there's a great book written by Peter Diamandis, the co-founder of Singularity University and the guy who leads the X Prizes. And his book's called Abundance. And he talks about what all this means with this exponential growth of data and technology and the abundance that it's providing. So another exponential growth is the number of internet users, from 2 billion to 5 billion users in the next 5 years. And this is a slide I put together for a talk I gave at HIMSS this last February, looking at the cycle, at the evolutionary time of new modes of communication. So from the letter to the telegraph took about 3,000 years. Telegraph to the internet was about 150 years. Internet to social networking, about 15 years. And you can see we're down to Facebook, 100 million to a billion in 3 years, and Pinterest, 0 to 10 million in 1 year. So we're seeing this compression of exponentiality and transformational issues. And the growth of collaboration is exponential in 3 dimensions: the number of collaborators, the number of collaboration platforms, and the number of accessible data types. So we're seeing a density of ideas and exchange and innovation that is unprecedented and still growing. So Peter Diamandis, again, made this great statement in his book. The rapid rise in connectedness, density, and rate of exchange of ideas has created a shift from local linear growth to global exponential growth of ideas and innovation. Disruptive stress is the gap between the human capacity to absorb change and the exponential growth of innovative technologies. So, LA Times published a cartoon June of last year showing a doctor with 8 hands, and there's 2 hands missing. Anybody want to take a guess at what hands are missing from this doctor experiencing the disruptive stress gap? EMR, a hand on a keyboard or a cell phone or whatever, and the other person said touching a patient. Exactly. Technology is getting in the way of the human connection. Someone once said in one of my talks, delivering a baby is the hand that's missing. It's just the coolest, ultimate symbol of touching the patient. So we're losing that. So how do we convert technology from a disruptive stress into a useful tool? We need to really manage the data-human-machine interface with intelligent sensing, validated sense-making of the data, validated triggers, an escalation process from machine to human with the ultimate goals of mindfulness. We need not to be responding to a flood of data. We need to use those data to help create mindfulness. So, and ultimately leading to wellness and happiness. Did anybody read January, February Harvard Business Review this year on happiness? The entire edition devoted to metrics, a couple folks of happiness. It's an amazing treasure trove. There are international metrics for happiness, and you know how the US scores poorly in healthcare? It's even worse for the measures of happiness. So we need to get away from this digital frame of reference and use that as a tool to get more to mindfulness, wellness, and happiness. So meaningful sensing. Pervasive sensing is not intrinsically virtuous. And so there have been a couple references to this in talks already today. But in a study published this April in the Archives of Internal Medicine, mortality increased 300% in the experimental group. It was monitored at home after discharge. Well, why is that? The author said, we can't explain it. What a bizarre finding. Well, it just so happens that the pervasive monitoring basically gave a signal to the patient. And that signal was, you're sick. You're sick. You're still sick. You're a little sicker. You're still sick. There's plenty of evidence showing that that kind of stress will raise your cortisol level. There's plenty of evidence that a rising cortisol level will impact your health adversely. I don't think it's a mystery. We have to be able to convert these streams of data into a sense of competence, a sense of control, a sense of autonomy, a sense of meaning for the individual. And then we'll see the control group do much better. And there was an allusion to that in one of the earlier talks. There's a whole lot of patterns. I'm going to skip that. Ultimately, the patterns of sensing must lead to mindfulness. Now, the Fitbit issue. So I think the way Fitbits are being used to sort of monitor everything you do every day, pedometers and all sorts of devices, the reason there's so many people with their hands up until I asked how many had one a day is because the recidivism is very high because we're not really incorporating it into our lives. So those who still have one and those who gave up, I would recommend you do the following. Instead of checking it every hour, or every 4 hours, or every day, challenge yourself to estimate what your Fitbit's going to tell you about what you did in the last 24 hours. And then go 2 days, and then go 4 days, and then go a week, and then go a month. And I'm not trying to hurt the Fitbit business because you still need a Fitbit to validate. But start extending the range of time where you're aware of how you are autonomously in control of your destiny and your health and wellness. So that's where mindfulness really comes in. Okay, 5 corollaries of meaningful sensing. There's a lot of stuff in here. I just go to number 5. We have a flood of information coming from the genome, the transcriptome, the proteome, the metabolome on one axis, the phenome, the microbiome, the environmentome on another axis, and the epigenome, the connectome, the neuroconnectome. Google that if you haven't looked at it, it's amazing, and the culturome. And so it's only the big data mashups between these very diverse sources of information that help us filter out where are the signals, what are the interrelationships that bring meaning, and how do we take these steady streams of data and convert them into something meaningful that will help bring about mindfulness and health and happiness. So the revolution in motivation science, suffice it to say, these 6 books are among my favorites. Connected, written by James Fowler, full professor of political science and genomics here at UCSD, amazing book. Nicholas Christakis of Harvard, we're going to be doing some work together pretty soon, talks about the influence of social networks on health. It is ground truth about social networks and health. Strongly recommend you read it. Only other one I mentioned is Drive by Daniel Pink. Talks about motivation 1.0, 2.0, and 3.0. He looks at the experimental literature over the past 40 years. This is old stuff. It's never taught in medical school. And he illustrates very clearly with old research that if you motivate people with the Motivation 1.0, which is food, shelter, sex, air, water, you know, it gets your basics. But Motivation 2.0, the carrots and sticks, is not very effective when you compare it with Motivation 3.0, which is why we all want to get up in the world and make the world a better place for our friends, our family, our loved ones, and our colleagues. And what he actually shows is that the carrots and sticks, in good experimental psychology studies, can actually impair the benefits and the sustaining capabilities of Motivation 3.0. So if I could, I'm going to show the quick video that talks about neuroplasticity and changing behaviors.
Long time across the lifespan, even in their 90s, and they can change if they're inspired to change.
To change your life, you have to change your mind. And the good news is, you can. Your brain cells have the power to build new pathways that will reinforce what you learn and do, including better health habits. This power is called neuroplasticity.
Neuroplasticity is the way the brain changes its structure in response to experience. Experience always means energy and information is flowing through the nervous system. So whenever you think experience, you have to think of neural firing. What we know is that when neurons repeatedly fire together, they wire together.
Brain cells, or neurons, pass impulses through branching arms called dendrites to other neurons. They can grow and form new, more efficient pathways. When you make a decision repeatedly, your brain forms a shortcut, helping the habit become nearly automatic.
So you do something continuously, whatever it is, a certain habit of reflection, a certain habit of thinking or feeling or doing, that will rewire your nervous system, and then you'll have a new habit. It's called long-term hetero and homosynaptic potentiation of neurons. I mean, that's the neural correlate of creating a habit, a new habit. You can't get rid of a habit unless you create a new habit.
What this all means is, healthy choices lead to more healthy choices.
So the important message there is that you can't just jettison a bad habit, you have to replace it with a good habit. And what I believe is really going on right now, just like healthcare is being rational and responding to irrational incentive and payment models, the consumer, all of us, are being rational in responding to all the behavioral cues for unhealthy habits and decisions. So we need to replace the existing cacophony of cues with what I like to refer to as the behavioral symphony of wellness. So the pervasive, always-on mobile interface is going to be a part of that behavioral symphony for wellness. So Clay Christensen has talked about the three enablers of disruptive technology: a simplifying technology, a business model innovation, and new value networks. So the simplifying technology is a smartphone and tablet and health avatars ultimately, and there are many, many, many startups doing health avatars. A business model innovation, which is consumer-driven healthcare, and a new value networks, which are social networks and gaming and social gaming. And then finally, I add to Clay's the burning platform of healthcare economics. So there are a lot of shifts that are going to happen, but I think the most important thing is that we need to hide the complexity of all these data behind a very intuitive UI, create this behavioral symphony for wellness through the integration of mobile gaming, social avatars, pervasive sensing, using analytics to understand what's working and what's not only for a cohort, but for an individual. We need to mass customize the communication and behavioral levers that we use to support each individual's priorities, decisions, objectives, and values for their own health, and focus on changing behaviors by supporting mindfulness. Oops, let me go back, sorry, to the full view here. Oh my goodness. Let me go back to slide 2, sorry about that. Okay, so in Daniel Pink's lexicon of motivation 1.0, 2.0, and 3.0, mobile is the platform, social networking is motivation 3.0, gaming is motivation 2.0, health avatars I assign a 3.1, sort of a super motivation, and then social gaming even beyond that. So the question for the next decade in my mind is who owns your avatar and why do you care? And so this is part of a bigger issue that I call the black box economy. So we all know that the global financial meltdown was due to credit default swaps, which came as a result of two things: an initiative to get everybody to own their own home and encourage liar loans, and then to package those liar loans and misrepresent what's inside them and sell them overseas and bring down the whole global economy. So that black box of credit default swaps was a new and valid technology, but it was abused by lack of transparency. The same thing is about to happen with every one of us in the avatars that we choose to use. So we're all more than willing to give personal information to an avatar to the extent that it helps us know which book Amazon recommends, know which music that Pandora recommends, and there's myriad examples. We all have avatars today, we just don't know it. They're very simple. But imagine when those avatars are across all of your interactions with the universe. And so who owns it? And how do we get transparency into what they want from us becomes very, very critical. I'm going to skip this slide in the interest of time. Oh, my machine went down. Okay. All right.
We move forward for you.
Yeah, I got a cue. Okay. So, wow, you've been tracking very well. So they took over running the slides. I didn't even know it. A couple of challenges and opportunities in healthcare analytics. The network is your brain doctor. So Sun Microsystems popularized the notion of the network is your computer. Well, there is already too much information for any physician in any specialty to keep up and know what to do. So the network is already the brain. Just wait until genomics and phenomics and all of the hundreds of thousands of rules come forward. There's already a chip from the University of Wisconsin that allows you to prescribe the right statin, the right antidepressant, the right anticonvulsant, that's across drug class, within drug class. And we know from our metabolic genomics and phenomics which one is going to be most beneficial for each one of you and which one is least likely to have the most side effects. It's going to be malpractice in 5 years to practice without that information, without that decision support. Great notion of privacy. We still need to protect every bit as we can, but I think everyone realizes that it's pretty much a losing battle in the digital world. And I'm going to speak to that in the panel this afternoon. And then who owns the data? Really, providers have a legal obligation to retain the data integrity and reproduce it on demand. Patients have a right to own it. So it's not an either-or question, it's a both and. Sorry state of healthcare analytics and mobile. Suffice it to say, the evidence basis for what we're doing is still in the dark ages. We need to come out of that with much better evidence-based reporting. Just a couple examples of gamification. These are two examples in healthcare. And then I'm going to summarize with what I see as the 10 keys to the future. So the first is the biggest challenges of our era are disorders of lifestyle. The second is the solution set is complex with a key behavioral foundation, which is not being taught in medical school, by the way. It needs to be desperately. We need to create a behavioral symphony for wellness, which allows people with rational behavior to follow the rational cues. The site of care is going to shift from where the physician lives to where the patient lives. Mobile, social gaming, avatar sensing, big data, analytics are all cornerstones to this wellness transformation and restoring healthy lifestyles, wellness, and happiness. Collaboration is critical, and open standards and platforms are key. Again, please, if you're developing a mobile app, look at Open mHealth and become part of the larger ecosystem. There's not going to be a killer app, there's going to be a killer ecosystem and lots of players. Sense making is core. Big data analytics may be old news to us, but the opportunities are still expanding exponentially as we see this compression of transformational time. The network is your brain doctor. We cannot function without, looks like we lost the slide, didn't we? We cannot function without the network, so high availability to the physician and coherence of messaging, direct to physician decision support, direct to consumer decision support is going to be key. Who owns your avatar and why do we care? Why do you care? And then finally, technology is only the catalyst for the digital doc support role and the consumer-directed healthcare. So the end state is about mindfulness and the path to health and happiness as the next stage of human evolution. So are we any chance of getting up the graphics for the last slides? Oh, next, down, keep going. There, okay. So this is a more optimistic view of human evolution with sort of the bionic embedded sensor loops, bionic man, and then The Rorschach I threw up at the very beginning is the next one. Next graphic. So this is evolution into a state of mindfulness. And so if we're really going to get beyond the digital stream of data and constantly telling us move left, move right, move more, move up, move down, to one of how do I take that information, become mindful, sleep right, exercise properly, take care of the people around me that I love and care about, and have them take care of me. So we already know from over a century of research on the blue zones, where people live to be 100 routinely. This is not a mystery. They have regular exercise, they have healthy, fresh food, they have a supportive social culture, and they take care of their emotional, spiritual, and social health. So we can use all of these technologies that we're all working on to help train us back to that state. But the irony is, the truth about wellness and health and happiness are centuries old. Thank you very much. Time for a few questions.
Based upon where your description of the condition of the market is, could you speak a few minutes on what wireless technologies mean to Kaiser at this moment? We saw some terrific numbers related to what you all are doing. Where have been the introductions maybe through the Garfield Center, and where have been the oops, we better wait for a while experiences?
So I filed patents about 4 years ago. It's sort of my vision of a architecture that did mass customization of behavioral levers to create the behavioral symphony of wellness, and taking all these data sources and learning from each individual what works and what doesn't work, and really creating a learning environment with mobile. And so the industry has gone much more down the path of, oh, there's just got to be a killer app and somebody just hasn't discovered it yet. So my view all along is we need to create an ecosystem that's an open modular architecture and based upon 3 levels of interoperability. One is at the platform level of open modular architectures. The second is at the semantic level for semantic interoperability. And the third is at the behavioral level, so that different apps for different conditions can use recognizably similar behavioral levers, so that an individual can use multiple apps and develop a familiar framework across the apps, as well as the same app can be used again across multiple people in the same social network, so that they can share experiences. So those 3 levels of interoperability are very, very important to me. And so I've been advocating very strongly for those within our company, and we're making a lot of progress in the last few months to build that ecosystem. We're working very closely with the Open M Health Initiative. I just joined their advisory board. We have literally scores of innovation projects in the field right now. We've done the basic blocking and tackling of mobilizing our existing services onto the mobile platform. So anything you get on the web previously, you can get now on a mobile platform. But we have a very large pipeline of apps. Now, some of those apps are completely internally developed. Most of them are developed in partnership with vendors like all of you. And some of them will be purchased off the shelf when they conform to the open modular architecture and ecosystem approach for the 3 levels of interoperability that I'm looking for. So Matthew Holt, one of the co-founders of Health 2.0, put me on the stage last year, and we're friends, and he basically put me on the spot and says, when are you going to announce what you're really doing? If you know Matthew, he's got this great style. And so my answer was, you know, the prerequisites to creating that ecosystem don't exist in the industry yet. We've been trying to develop them internally. The Open M Health platform is really a giant step in the right direction. We donated just a year or 2 ago our medical terminology into the National Library of Medicine and the International Standards Arena, so that what we have there is we have a mapping of consumer-grade terminology with professional-grade terminology to address some of the semantic issues, so that we can use the information between our health record and personal health record and mobile apps. So there's a whole lot of things that need to exist to really create a fertile ecosystem to bring all of this together. But our expectation, my expectation from the outset, has not been that we will build them all. Quite the contrary. I want to get lots of help from all of you to the extent that you can conform to open standards, open modular architectures, and fit within that ecosystem. So my vision is that we will have every physician in our program in 5 years with a formulary of health apps that they prescribe, just like hopefully instead of medications more often than not, and provide a set of apps that are mass customized to the individual by which apps, and are further mass customized to them in terms of what features and functions in those apps work for them. So we don't have the kind of attrition rate we illustrated earlier with Fitbit. We want to have people starting the apps and continue using the apps, and I see a way where we actually have app coaches in our clinics. So when the doctor sees a patient, prescribes 3 apps, before they can check out, they get those loaded on their smartphone or smart tablet, and they're already started on using them, and when they come back for a follow-up visit, when they need a face-to-face, they can review how's it going, which levers are working for you, how can we better make it work for you, how can we adapt it to your personal goals and objectives and values, so that we're not doing one size fits all, but we're actually helping people choose their own goal. And the behavioral sciences around this is incredible. People choosing their own goals and how we're supporting their goals is far more effective and powerful than us saying, here's what we're going to do for you now, go do this stuff. It's like, go stop smoking. It just doesn't work. So to the extent that we're creating that ecosystem, we have scores of projects and pilot, to the extent that we're doing strategic partnerships with lots of vendors in the space, to the extent that the industry shifts to more of an open modular architecture with interoperability across those 3 spaces, we're going to see an exponential growth in what we offer in our own app store in the not too distant future. But it's very difficult now to go from this everybody trying to produce a killer app to actually being a player in the ecosystem. Yes.
Yes, I have a question. First of all, I want to thank you for, I'm over here. I'd like to thank you for such a wonderful talk and connecting all the dots and acknowledging that we all have the power and ability within us to heal ourselves and to sustain our health and well-being. So given that that's where we want to go, is Kaiser working on clinical outcomes validations using mindfulness-based stress reduction or any of the other?
I'm sorry, using what? I couldn't hear.
Mindfulness-based stress reduction or any of the other types of mindfulness modalities?
We really did a lot of the pioneering work for evidence-based medicine and predictive modeling. The work with David Eddy, who's sort of the grandfather of evidence-based medicine. I worked very closely with him in the early 90s when he was developing the Archimedes modeling tool. So we have a very, very strong pedigree in evidence-based decision-making. It's very difficult to do that in the mobile space today, but there are, as you are obviously well aware, and I'd love to talk to you afterwards, there are lots of scales that you can use to measure individual resilience, individual competence and proficiency, community resilience and competence, and there's a whole new genre of research that looks at digital equity in communities in terms of as a policy issue for how, and again, watch Weight of the Nation, it speaks to this very directly about how we have these nutritional deserts in the inner city. There's no way anybody in the inner city could live a healthy lifestyle. You cannot find fresh food. They did a survey of kids in the ghettos back east, I think in Baltimore, and they showed them a picture of a drumstick and a chicken wing from Colonel Sanders, and they showed them a McNugget from McDonald's. And the kids literally didn't even know that the chicken wing and the drumstick actually came from a chicken. They recognized the McNugget as being, that's the only thing they ever saw as chicken. So there's a digital equity problem that's an amplification of the digital divide that we need to address. But these kinds of metrics around resilience and competence and the behavioral tools are emerging. I'm actually working closely with someone who's developing essentially an MMPI, which is how you profile someone's personality, essentially an MMPI for behavioral levers in healthcare, so that we can apply that to every one of our patients before we prescribe an app, and then match their fingerprint with that behavioral profile against an app, and then measure against that and watch the changes in those behavioral metrics. So you are right on the money, and it's a huge interest of mine, so I'd love to talk to you more later and get some ideas from you as well. One last question.
Thank you, Dr. Mattison. We're cutting into the lunchtime, so we're going to break for lunch if you don't mind, and you can talk to Dr. Mattison right after this.
Thanks very much.